Hello everyone, welcome back to the channel. So today we'll be discussing splenomegaly, which is an easy but important concept for pathology and of course all of your clinical postings as well. So a normal spleen weighs 150 grams and is non-palpable. It's covered by a thin, glistening gray connective tissue capsule, and its stroma is broadly divided into red pulp and white pulp, which I shall now depict in a diagram. So we have the central artery which branches out into peninsular arteries, and the blood from here drains into sinusoids which eventually drain into the trabecular vein which emerges through the hilum. So we have a periarteriolar lymphoid sheath around the central artery which expands at many places to form lymphoid follicles with actively proliferating germinal centers, and in between the venous sinuses you have the splenic cords of Billroth, basically a bunch of macrophages. The sinusoid's endothelium is discontinuous, so what happens is RBCs exit the sinusoids, traverse through the cords of Billroth and re-enter another sinusoid. So if there's any bad RBC, it'll be trapped by the dendritic processes of the macrophages and it won't make it out basically. So what are the functions of the spleen? It is, of course, first and foremost is phagocytosis of blood cells and particulate matter. It's called the graveyard of RBCs for a reason. And other functions are antibody production, and in very rare cases or extreme cases, if required, hematopoiesis also. It's one of the sites of hematopoiesis in the embryonic stage as well. So when RBCs pass through the cords of Billroth, it's called an open circuit as it exits circulation. Closed circuit is when it directly enters a sinusoid from an arteriole. Due to the action of splenic macrophages, many inclusion bodies are formed in RBCs, and two important ones are Heinz bodies seen in G6PD deficiency and Howell-Jolly bodies seen in sickle cell anemia. Spleen is rarely the primary site of disease. Splenomegaly is usually secondary to a lot of diseases. So, another thing to be noted is that asplenic individuals need vaccination against these three pathogens: Streptococcus pneumoniae, Neisseria meningitidis, and Haemophilus influenzae. Streptococcus pneumoniae vaccination is of top priority among asplenic individuals. So splenomegaly is basically when the spleen is enlarged so much that it now becomes palpable. So it can lead to a condition called hypersplenism, in which you have anemia, leukopenia and thrombocytopenia. So the various causes of splenomegaly are infections, congestive splenomegaly, which is secondary to portal hypertension, lymphohematogenous disorders, immunologic or inflammatory, storage diseases and other miscellaneous causes. So under infections, you can have non-specific splenitis to various bloodborne infections, especially infective endocarditis, then infectious mononucleosis, TB, enteric fever, brucellosis, malaria, toxoplasmosis, echinococcosis, cytomegaloviral infection, Kala Azar, and syphilis. Under congestive causes, it can be due to liver cirrhosis or portal or splenic vein thrombosis or cardiac failure. And on the lymphohematogenous disorders, we have Hodgkin's lymphoma, non-Hodgkin's lymphoma, multiple myeloma, myeloproliferative neoplasms like AML, CML, myelodysplastic syndrome, hemolytic anemia like G6PD deficiency and autoimmune hemolytic anemias, along with lymphocytic leukemias as well. Under inflammatory causes, we have the main two causes are rheumatoid arthritis and systemic lupus erythematosus. Storage diseases, we have Gaucher's disease, Niemann-Pick's disease and mucopolysaccharidosis. And these are the causative enzymes that I've written here. And under miscellaneous, we have amyloidosis, primary neoplasms and cysts, secondary neoplasms as well. By the way, it's not just pathogens. Excess of cytokines in response to inflammation can cause non-specific splenitis and acute red pulp congestion. Streptococcus pyogenes is notorious for causing white pulp necrosis. In congestive splenomegaly, the capsule thickens and becomes firm in consistency. A notable cause is schistosomiasis, wherein there is severe congestion due to pipe stem hepatic fibrosis. An enlarged spleen weighs 1 to 5 kgs. The spleen is very much prone to infarcts as the arteries supplying it are physiologically end arteries and it would enter coagulative necrosis. So if you have septic infarcts, it's indicative of infective endocarditis of mitral or aortic valves. Splenomegaly predisposes to infarction as the blood supply of the spleen is tenuous and can get easily compromised. So coming to other spleen pathologies, we have neoplasms in which the most common ones are lymphangiomas and cavernous hemangiomas. Benign fibromas, osteomas and chondromas are also fairly common. And then congenital anomalies, we have asplenia, which is associated with cardiac malformations. The most common scenario being situs inversus. And we have accessory spleens, also called spleniculi, which can be found anywhere in the abdomen. And lastly, we have splenic rupture, which can be due to blunt trauma, due to any predisposing conditions like infectious mononucleosis, malaria, enteric fever, and lymphoid neoplasms. Basically, any full-blown acute splenomegaly. And chronic causes can be due to capsule thickening and fibrosis of the stroma. And other complications like intraperitoneal hemorrhage can also cause rupture. So that's it for today, guys. This is all about splenomegaly. I hope this is helpful. Thank you for watching. Please watch this video with Robbins by your side for best effect. And if you have any suggestions, you can comment down below. Please like, share and subscribe. Thank you once again.